Recording in progress.
What did I do?
Good morning, Masi. Are we ready to go?
Good morning, Chairperson. Yes, we can proceed, Chair.
Morning, Honorable Chairperson.
Good morning.
Yes, Mercy.
Honorable Tlaba.
Uyitholile ngithi apology yami kulo unobhala we-study group sam.
Yes, Honorable Tlaba. I've sent that to the Chairperson.
All right, thank you.
Wonderful. Thank you very much, members, and welcome to this morning to our committee, let me take this opportunity to just welcome everybody present. We have Deputy Minister Kekana here, we have the members of the committee, we have the staff and the representatives, different representatives from GEMS who will be presenting to us. A warm welcome to everybody present. I would just like to take a special take a moment to just say thank you for Deputy Minister to be with us. As per our standard procedure, members, we're going to just start by adopting the agenda. I would like to just ask the staff to please flight the agenda before we start. There we have it, members. It's on the screen. It's being shared. Can I please ask for a nomination to adopt the agenda for today's meeting? I see Honourable Potgieter's hand. Honourable Potgieter, please proceed.
Chair, I move for adoption of the agenda.
Thank you very much. Noted. Honourable Malinga.
Second, the adoption of the agenda, Chairperson. Thank you.
Thank you very much, Honourable Malinga. That means our agenda has been duly adopted and we can proceed as planned. Members, before we move on, I would like to just request from both members of the committee as well as all other speakers that if you could please just turn on your video when you start speaking, and I will allow you to turn off your video as soon as we've just seen you and you've just presented yourself to the committee. I understand that because it is virtual, that not everybody has access to reliable internet or broadband, and we'd like to keep our connections as good as possible. But as a standard procedure, as we discussed in our previous meeting as well, I would like to please urge all speakers, members of the committee and presenters, to just turn on their video when they speak before we and thereafter they can turn it off as to just show your face to us. Thank you very much, members. Apologies. We have a standing apology for Honourable Pulwane, and we have received an apology for Honourable Legape. So, members, if there are any other apologies to note, this is now the opportunity to do so. I see no hands, so those are the two apologies that we can note, and then we can move on to the next item of our agenda. Members, over our previous several committee engagements with the Government Employees Medical Scheme, which is GEMS, members of the committee felt that it is critically important for the scheme to provide a comprehensive view about its functions to the members of the public servants and its administrative and management affairs within its own institution. We have thus invited GEMS to provide the committee with a comprehensive view to assist us to hold it accountable from a well-informed position as it reports under the ministry of the DPSA, and it's about assisting our public servants to remain healthy as they provide public services to the citizens. We believe after this presentation, members will be empowered about the affairs of GEMS, and we really look forward to it. But with those few words, I'm just going to give the Deputy Minister an opportunity to also provide some opening remarks, whereafter we will move on to the presentation from GEMS. Deputy Minister Kekana, you are welcome to open the floor.
Chairperson, thank you very much for this opportunity, and thanks to honorable members. With me is the leadership of GEMS, led by the PO, Principal Officer from admin side, and I hope the chair of the board and other members are here. As agreed, and you have outlined the reason why we are here, to take the committee through how GEMS was formed, how it is performing, what form of support, oversight role the committee should play to make sure that they are able to have a hand over one of the entities of DPSA. Of course, you'll remember even when we made a presentation in Parliament, when we were physical, the PO and the chair also outlined to the committee that this is one of the biggest medical aid scheme in the country because it hosts quite a bigger chunk of our public servants. So I'm going to allow the PO and the team and the chair, if she is around, to take the committee through. Thank you.
Thank you, Honorable Deputy Minister, for that introduction. We are present in this meeting. Honorable Chairperson of the DPSA Portfolio Committee and members, Minister of the DPSA and the Deputy Minister, and all the various heads of entities in the Ministry of the Public Service and Administration present in this meeting. We'd like to greet you this morning. I'm not sure if I'm visible on the camera, but it is my honor to be given this opportunity, and thank you for your continued interest in the work and impact of the Government Employees Medical Scheme as a critical organization within the South Africa's healthcare landscape. GEMS is a restricted, meaning it's a closed medical scheme. It serves the public service employees, and it is governed by 12 members of the Board of Trustees under the Medical Schemes Act, MSA, and the scheme's rules. The board exercises its full governance oversight in compliance with the legislative prescripts, with equal representation from employer-appointed and a member-elected trustees board. That's what constitutes the Board of Trustees. Honorable Minister of the Deputy of the Department of Public Service and Administration, it is our principal as the employer and the government representative. So that's Inkosi Mzamo, Minister of Public Service and Administration, Nkosi Mzamo Buthelezi. GEMS operates as a non-profit organization, pooling funds on behalf of the members to defray the healthcare costs when needed. This is done in accordance with the scheme rules. The scheme remains committed to affordability, transparency, and accountability while offering a range of benefits, options tailored to members' healthcare and needs. It has over 389,000 claims processed daily to defray the members' healthcare costs. GEMS is the largest restricted medical scheme in South Africa, and it continues to navigate economic pressures with care, resilience, and innovation. On the recent release of the Section 59 panel investigation report, we will be working closely with the Council for Medical Schemes, CMS. Section 59 expects healthcare providers and our members to ensure that all the fraud, waste, and abuse systems are fair, transparent, and fully compliant with the national laws of Section 59 report, as recommended. We are reaching out to the regulator, who is CMS, with due regard to what the law allows for a meeting to pursue this further. Further details on this matter are contained in the presentation that the principal officer and the executive management team is about to give. May I conclude by reiterating, Chair, that GEMS' long-held position that to access healthcare is a basic human right enshrined in the Constitution under the Bill of Rights of this country. GEMS remains steadfast on its mission. It is to provide all its members with equitable access to affordable healthcare and comprehensive quality healthcare, promoting member well-being. As per our mandate, we will continue to ensure that there is adequately healthcare coverage for public service employees. Lastly, Chairperson, we are committed to our strategic trust, which is to be a strategic partner in the healthcare and the universal healthcare coverage of the country. I thank you, Chairperson, and now hand over to the Principal Officer and the Executive Management team to give a more detailed presentation on what we were requested to prepare for the Portfolio Committee. Thank you. Dr. Sten, over to you.
Thank you. Thank you very much, Chairperson. Thank you for the introduction. Thank you, DM, to the Chairperson of the Portfolio Committee and the members of the Portfolio Committee, and to colleagues who are accompanying me from the Executive Management team. We are going to present in line with what we were requested as the DM indicated in the introduction. I am going to do sections of the presentation that we have shared with the office, the Secretariat of the committee. I am accompanied by colleagues in the executive team of GEMS. The agenda that we're going to talk to, I will give a background to the formation of GEMS, and then Ms. Masima Singita, who is our executive manager and the OPO responsible for strategy, will talk to GEMS strategic positioning. I will then talk to the medical schemes environment that GEMS operates in, and just brief on the leadership that the chairperson of the board has already alluded to. Then my colleague, Dr. Vuyo Gola, will then talk to operations overview. She is the Chief Operations Officer of the scheme, and talk to the challenges confronting the scheme members. And then she'll hand over to our colleague, the CFO, Ms. Karina van Lingen. And then I will finish off just giving a brief on GEMS' position on the Section 59 panel investigation final report that was released on the 7th, as the chairperson has indicated, and then summarize. So GEMS was established and with the realization that access to healthcare is a basic human right that is enshrined in the Constitution of South Africa under the Bill of Rights. In 2004, there was a cabinet note that there is a need to create a medical scheme that is specifically for public service employees. At that time, the population of South Africa was 52 million, and 16,000, only 16% of the population belonged to medical schemes. That hasn't changed much. The percentage of people on the medical scheme haven't changed much, albeit that over the years, GEMS has added over 1 million beneficiaries. Members must be differentiated from beneficiaries. The members of GEMS are at the moment 887,000. But GEMS is responsible for over 2.4 million beneficiaries. And before the formation of GEMS, over 1 million of those were not on medical schemes. And we have therefore managed to deliver over the 20 years that GEMS has been in existence on the mandate that was given by that cabinet note. So the cabinet made a decision in 2002. The Department of Public Service and Administration was to create a dedicated medical scheme for public service employees. A project was then started to investigate the formation of a medical scheme specifically for government health employees. During that period between 2002 and 2004, there was a lot of consultation between organized labor government departments, and healthcare sector stakeholders. And labor was included as they would represent the needs of employees across all income levels. They played a critical role in shaping the benefit design, the affordability structures, and the proposed governance mechanism that GEMS would be subjected to. Their involvement assisted to build trust, promote uptake, and ensure alignment with the collective bargaining frameworks. And if you check the PSCBC, there are resolutions from 2006, starting with, in fact, it's before 2006, which was supporting the formation of GEMS. But Resolution 1 of 2006 was the most important one, where there was agreement with labor on the subsidies relating to the government employees medical scheme. The various departments, including the DPSA, National Treasury, were involved to ensure policy coherence and that there should be financial viability when the scheme was formed. The structure of employer contribution as a subsidy models were developed with consultation with all these departments, with the main aim being that the scheme must be affordable and sustainable. And then there was also collaboration with the various departments on the rollout strategy. There was member education and administrative systems that were put in place. Consultations were also held with healthcare providers, regulators. The regulator, for the reason that GEMS was to be registered as a medical scheme under the Medical Schemes Act, as the chairperson has indicated. And also health economics were to assist in modeling what the benefits would be like. There were inputs that were sought to shape the benefit packages in a manner that was supposed to be evidence-based, actuarially sound, and aligned to what the needs of the employees would be, so as to also align with the national health priority. This groundwork also led to engagement with provider health payers, so that the GEMS operates based on managed healthcare principles to ensure that there's cost containment. So GEMS was then registered as a medical scheme in 2005 under the Medical Schemes Act. And this is to ensure that there is oversight from the regulator, which governs transparency, solvency, and most importantly, the CMS as the regulator is there to protect the member interests. So the scheme was registered January 2005, and the work to prepare the administration, how a model of GEMS was done during 2005. In December 2005, our first member was registered, and then GEMS started operating January 2006. As we have stated, GEMS is a restricted membership scheme which enrolls public service employees, and then the eligible dependents are also put on the medical scheme. The restriction ensures that the scheme is focused on the unique needs of government employees, and some of the benefits continue to be tailored based on employer subsidy model, specifically designed for the public service employees. The most important thing that was anticipated and has actually materialized is that GEMS was going to be a big full risk with a defined population, and this would allow managing the funds within this risk pool. After the registration of GEMS in January 2006, the rollout was supported by government, and there was a campaign to raise awareness that members who are on other medical schemes, members who are not, especially the low-income government employees who were not on schemes, were encouraged to join the scheme with very favorable subsidy arrangements. As a result, GEMS experienced an exponential growth in memberships, with a lot of members moving from other open medical scheme and also low-income public service employees who did not belong to medical scheme started joining GEMS. The surge among lower-income employees was welcome because this was exactly the intention of GEMS, to have those who had affordability barriers join a medical scheme. The other things that also were favorable in terms of GEMS was inclusive tiered benefit options. And that will be, Dr. Vuyo will talk to it will be Ms. Masingita who will talk to the various options. There are various options that are there to allow for a member to choose an option that is in line with their affordability and the needs of the family that will be covered. And then also the tiered structure of these options is based also on income bands, and it enhances the ability to choose where one is able to afford, but also informed by the health care needs. Over time, as the members were joining, there was also areas that needed improvement. And then one of our options was actually changed after members were not happy with some of the benefits. In consultation with Labour, the then Sapphire options became what is now known as the Tanzanite 1 option. I will hand over to my colleague to take a few slides. I will drive the slides for you, Masi.
Thank you so much, Dr. Stan. I'm not sure if my video is on. Just checking. Have switched it on. Dr. Stan, if you could just confirm if my video is on. I'm not sure because I'm not able to.
I can't see. I don't have a split because I've loaded the presentation. I don't have a split view.
Let me just.
No, the video is on. We can see you.
Thank you so much.
Masi?
Yes, Dr. Stan?
I think you should press that button on your keyboard. There we go.
Awesome. Thank you so much, Dr. Stan. To the chairperson of the Portfolio Committee, the Minister of Public Service and Administration, the Deputy Minister, board members and colleagues, all protocol observed. I will focus on giving the strategic view of GEMS. As Dr. Stan has highlighted, GEMS was set up in 2005, and to date, the GEMS mandate hasn't changed. It remains to ensure that there is adequate provisioning of healthcare coverage to public service employees that is efficient, cost-effective, and equitable. And in addition to that, we also ensure that we provide further options for those who wish to purchase more extensive cover. Next slide, Dr. Stan.
Sorry.
This slide, I will focus on the vision and mission and
Sorry, Masi. I don't know if you've muted.
coverage include equity, include quality, include accessibility. From an equity perspective, we're talking about providing access regardless of social or economic status. From a quality perspective, we want to ensure that healthcare services must be effective, it must be safe for our members, and must meet our members' needs. From an accessibility perspective, we need to ensure that the principles of universal healthcare coverage says as a healthcare service must be available for where people live and where they work. From a mission perspective, is we provide all members with equitable access to affordable and comprehensive quality healthcare, promoting member well-being. As part of the way we execute our mandate, GEMS has a 2022 to 2026 strategy that was approved by the board. As part of the strategy, what's enshrined in there is what we call our strategic thrust. The chairperson of the board in her opening made reference to the strategic thrust, which is to be a strategic partner towards the realization of universal healthcare coverage. In ensuring that we integrated this strategic thrust is just so that we can ensure that we continue to execute our mandate in providing healthcare to our members while we are progressive in responding to government plan to implement the national health insurance, which is aligned to the universal healthcare coverage. So in our strategy, we remain committed to supporting government in the implementation of NHI. And next slide, Dr. Sen. From a GEMS values perspective, as we execute our mandate, what's embedded in our mandate is in the way that we behave from a values perspective. So we've got 5 values that govern the way that we behave from a GEMS perspective. It's collaboration, it's innovation, it's member value, it's excellence, and it's its integrity. Each of the value, we align it to a color that's associated with the GEMS logo. From a collaboration perspective, we say collaboration is gray and it is the center of the GEMS logo. And it's gray and it's center of the GEMS logo, and it's everything that we do, which means that we are results orientated. We drive towards common goals and we drive member satisfaction, actually inclusive stakeholder satisfaction, which includes our members, our providers, and the rest of our stakeholders. From an innovation perspective, we're saying innovation is gold as it presents a golden opportunity to be creative and bring out of the box thinking. So one of the things that we focus on is that we look at opportunities to enhance our service and to enhance our product. So we innovate our product on an annual basis, and we continuously innovate our services as well. We're solution driven, and we want to build confidence with our service providers in the way that we provide products and services. From a member value perspective, the member value is green as it signifies growth of the scheme that seeks to achieve. Dr. Stan, when he presented, he showed elements of where we've seen from the time that GEMS was created to date, we've seen GEMS grow, and which shows that in essence, we are meeting our member needs. So we continue to look at the way in which we recruit the people that service GEMS. We look for competence, we look for high-skilled people so that we have a competent staff and a competent workforce. We want people to be able to execute with speed, because we do understand that as we service our members, these are life and death type of situations. And the way and the rate in which we execute, we need to ensure that we're always ready to respond to member needs. From an excellence perspective, we're saying excellence is blue and it resembles the sky. We are number one scheme and we say the sky is not the limit. We are not shy to say that we are the number one scheme because we pride ourselves on performance. We're a performance-driven culture organization. We thrive on delivery and we thrive on consistency. What we're saying that when a member engages with anybody at GEMS, there is a consistent way in which we service them, and we pride ourselves on that. From an integrity perspective, we're saying integrity is red and it shows zero tolerance for corruption. That means we are very, very decisive in responding to anything that compromises our integrity. And we have systems and processes and policies in place to be able to respond to that. We operate within trust amongst ourselves as staff members, together with the board. We also ensure that our stakeholders and our members trust in us in providing our services, and we provide peace of mind. Dr. Sen, next slide. So we mentioned that our strategic thrust is to be a strategic partner in the realization of UHC. Some of the areas that we focus on and the initiatives towards driving our support towards NHI speaks to NHI reference product. We have what we call a Tanzanite 1 product. Dr. Sten mentioned it. It's one that is actually has evolved over the years. It used to be called Sapphire. There was a lot of work that was done listening to the member needs and member requirements, and through road shows, through the AGM, where members were saying that the Sapphire product needed to be relooked at. So as the scheme, we worked hard on that to ensure that we respond to that. And we call it an NHI reference product because it mirrors what we call a basic benefit package. It is enshrined with care coordination, where we're saying that from a coordinated care perspective, we promote that all our members must be able to nominate a general practitioner or a family practitioner. In this way, the family practitioner will be able to ensure that there is a coordinated way in which they look at their health. And equal to that, the GP will be responsible for referring our members to any specialist consultation that will be required based on their assessment and their initial consultation with them. And we have what we call various networks that have been created to be able to support this product through our a division called healthcare management. We do what we call tariff negotiations with specialist groups, hospital groups, to ensure that we are able to negotiate favorable rates that promote member affordability. And through this, we also contract with specific service providers to ensure that when they service our members, they stick to the rules and they stick to those tariffs so that members don't experience co-payments. From an equitable and income-based contribution perspective, Dr. Sten also mentioned it as well, in that our contribution are based on income. And in this way, we are saying that we drive affordability for our members. Members look at their income band and are able to choose options that are able to suit their needs and their families' needs. One of the things that we also drive is better healthcare outcomes. We pursue achievement of above industry indicators towards Sustainable Development Goals 3. And in this, what we do is that we do mirror ourselves against our competitors. We look at what is happening out there. We continuously promote our service, and we continuously enhance and improve our products, including ensuring that we monitor and evaluate the way our healthcare providers actually service our members, so that we make sure that our members are getting value for money and we are driving healthcare outcomes. It's not about the number of visits, it's about the outcome that you get from the visit, and ensuring that a holistic view of member health, we have visibility of that. And we've got specific performance indicators that have been agreed upon with service providers that we monitor them against. One of the things that we look at is low non-healthcare cost. We are amongst the lowest non-healthcare costs in the medical aid sector. Our CFO will also speak to this in detail. But basically what we are driving here is to ensure that when we drive efficiencies at head office, as we service our members, we make sure that the efficiencies reduce the cost from a healthcare, from a head office perspective, so that these costs are not translated into contribution for members. We continuously look at measures in the head office to ensure that we continuously drive initiatives, projects that can help us still maintain being one of the lowest in healthcare costs, in non-healthcare costs in the medical aid industry. Our CFO will deliberate a little bit more on this when she speaks to the financials. From a leadership and governance perspective, when the chairperson of the board opened, the chairperson highlighted the fact that we are governed by a board of trustees, and a board of trustees is also governed by the board charter. And what we support from a GEMS perspective through the effective oversight of our board is ethical leadership. One of the things that we also do is that we've got policies, ethical policies, we've got channels, whistleblowing channels, where we are open and we encourage people to whistleblow where they see areas where ethical leadership is being compromised, or ethics from a GEMS perspective is being compromised. We also do ethical training with the whole of staff, especially those staff that also interface with our members and our providers. From a controls perspective, we've got strict financial controls at GEMS, and we pride ourselves on that. And this is evidenced by the 18 unqualified audits since inception. This simply means that through the board oversight, there is effective governance in the way that we execute our mandate to ensure that there is not mismanagement of funds, and as I mentioned earlier, low non-tolerance of corruption. So the 18 unqualified audits is one we celebrate, and it is one that we communicate broadly even to our members to give our members comfort in the way that we govern the scheme. Next slide, Dr. Stan. Dr. Stan, I think you skipped the benefits. Slide 12, yes. Thank you, Dr. Stan. Just to go a little bit into the GEMS benefit options. So GEMS has 5 benefit options and one option that we call an efficiency discount option. The 5 benefit options are Tanzanite 1, Beryl, Ruby, Emerald, and Onyx, and with Emerald value being that efficiency discount option. From a Tanzanite 1 perspective, Tanzanite 1 is our entry-level care coordination network option. It's the option that I was referring to where I was talking about the option that mirrors the basic benefit package that is referred to in the implementation of NHI. So with Tanzanite 1, the benefits that are there is in-hospital benefits within a defined hospital network, and it's subject to annual hospital limit. Out-of-hospital benefits subject to GEMS network and family practitioner nomination and specialist rules. One of the things that we promote across all members, regardless of which option you choose, is care coordination. With Tanzanite 1, members need to nominate a family practitioner that will ultimately coordinate their care and will be their reference point to referring them to specialists should it be required. One of the things that must also be noted around the specific option is that with the use of a family practitioner, a nominated family practitioner, members then avoid co-payments. It is only when they go outside of a nominated family practitioner then they face the risk of co-payments. From a Beryl perspective, it's another entry-level network option. It's got in-hospital benefits subject to an annual hospital limit, out-of-hospital benefits subject to a GEMS network. Again, this is one where we do encourage members that even if they are on this option, they do nominate a family practitioner. However, within this specific option, there isn't a penalty if you don't nominate a family practitioner. The next option is a Ruby option. It's a mid-level savings option. It's got embedded in it what we call a personal medical savings account, where 20% of the contributions are allocated to the savings account under the member's name. So the member can use this savings account to be able to pay for out-of-pocket hospital or day-to-day benefits or medical services that they require. It's also got out-of-hospital benefits subject to the savings account, like I mentioned, and a block benefit. The next option is Emerald, and this one is a high-level benefit option. It's got comprehensive in-hospital benefits, comprehensive out-of-hospital benefits subject to day-to-day block benefit, primary care extender benefit. Again, this option a member would not be penalized if a family practitioner is not nominated, even though it is an area that we encourage. Then we have Onyx, which is our top level benefit option. It's also a comprehensive in-hospital benefit, comprehensive out-of-hospital benefit, subject to a high value day-to-day block benefit. And then we have what we call Emerald Value. Emerald Value is a care coordinated network option. It's an efficiency discount option where we are negotiations had to be done, or a research had to be done to create an option like this that mirrors the Emerald option. However, what distinguishes from the Emerald option is that it is also subject to a defined hospital network. It does have comprehensive out-of-hospital benefits such as subject to GEMS network, FP nomination, and day-to-day block benefits. One of the things that is a benefit across all the options, as I reiterate, is the element of care coordination. The benefit of care coordination also ensures that we also minimize the element of fraud, waste, and abuse, where practitioners abuse seeing members without necessarily getting driving the right healthcare outcomes. So if it is coordinated through a family practitioner, then through a family practitioner, we are able to then see how the referrals are happening to the specialist, and based on the needs of a member, not necessarily induced by the providers. Thank you so much, Dr. Stan.
Thank you, Marcy. I will take the next few slides, and then my presentation is not. So we basically then committee chairperson of the committee and committee members. The next few slides, in line with the request we received, is to share how medical schemes work. Because we are a medical scheme, GEMS is a medical scheme. It operates within a defined environment. So a medical scheme is it's a non-profit organization. It is governed, as in the introduction by the chairperson, it is governed by a board of trustees, and it must be registered to the Council for Medical Schemes. We are registered to the Council for Medical Schemes. Medical schemes do not have shareholders. Medical schemes do not pay dividends. The scheme income, is derived solely from member contribution, and because we keep reserves as required by the Act, those reserves then bear investment returns, which our CFO will talk to. So the way a medical scheme acts, I always describe it as a stock fair. The schemes receive the contributions, it pools those contributions, and then using these contributions, it defrays the healthcare costs. And this is done and planned for and budgeted for on a year-to-year basis. Any surplus funds that are there, they are transferred in accordance with the regulations to the scheme reserved. And this is for instances where a medical scheme, for whatever reasons, may not be receiving contribution in income. The arbitrary calculation is that a scheme should be able has a reserve that would keep it going for about 4 months without receiving any income. So this is for the benefit of members. So that's generally what the reserves are for. A medical scheme, therefore, does not make profits. Everywhere when you budget such that you take care of where there are shortfalls, and then if they are, depending on the claims, you have reserves, and then you budget accordingly the following year. No profits are distributed. The scheme exists for their members. As we have indicated, all funds are pooled and safeguarded to pay claims in accordance with the scheme's rules and ensure that all members are equitably and fairly cared for relative to their choice of benefit plan and based on their healthcare needs. All medical schemes in South Africa operate in terms of the Medical Schemes Act 131 of 1998 and its regulations, and are regulated by the Council for Medical Schemes. Restricted medical schemes like GEMS are administered on behalf of the employer for their staff and their families, or people working within a particular industry. So in our instance, the public service, the Department of Public Service and Administration is the employer on behalf of government. Whereas open schemes are open to the public and anyone can join as long as they are an adult. They are not a member of any other medical scheme. So in terms of the law, you can only be a member of one medical scheme. And as long as they can afford the contributions, then they can join any of the medical schemes out there. And I think we have 71 medical schemes in the country. 20 are open medical scheme and 50, plus minus, I think 51 are closed medical scheme. So just to further show how a medical schemes work, we have you enroll to a medical scheme that you are eligible for. In our case, GEMS, you have to be a public service employee. And then after joining, your contribution is determined, and on a monthly you contribute. If you have a healthcare need, you go to the doctor, or you end up in a hospital, we call it a healthcare encounter or an event. And then once the healthcare services have been rendered, before they are rendered, some healthcare establishments will let you know if there are going to be any co-pays. However, if you use the networks where we have agreements with the healthcare providers that they will charge the medical scheme tariffs, there should not be co-payments. Then the healthcare provides the services, the healthcare provider, and then after that, the healthcare provider basically submits a claim or reimbursement request to the medical scheme. We then assess it and then pay directly to the healthcare provider. This part 6 and 7 are very important. We call it a third-party payment. And if we were to ask why is there fraud, waste and abuse in the system, it is because of this arrangement. Unlike if you need a commodity like bread, you go in a shop, you come out with bread, you know what you've paid for. This arrangement, you go in the hospital, you are very sick, you are vulnerable, they take care of you. Sometimes they don't even give you the account. So I thought I should just mention that, because fraud, waste, and abuse is one of the things that is the challenges that we are faced with. That's the detail of what I've just demonstrated, but we thought it's important, so I'm just gonna reiterate it. It's enrollment to a medical scheme. An individual joins a medical scheme and becomes a member. Having selected a benefit plan, Marcy has indicated we have 5 plans and 1 efficiency discount option, and you choose based on your budget and your healthcare needs. Then a member pays monthly contribution. In our instance, there is also there's a member portion which is part of their agreement with the employer, and then there is also a subsidy portion based on what has been agreed. Sometimes when a member joins, in fact not sometimes now, every time, because we have changed over the years, our underwriting has become more stringent because of the claims experience that we are having and the anti-selection. And anti-selection simply means members who either join or they bring on beneficiaries who qualify. They pay for a few months because they already knew that there's a pre-existing condition. They claim. After they have claimed, we pay accounts in excess of what they have contributed, and then when the beneficiary is okay, they leave the scheme. So to overcome this, we now have waiting periods. These waiting periods are in accordance with the Medical Schemes Act. Service providers like doctors and hospitals, they submit claims to the scheme, and then we then basically assess these claims and pay if they are in accordance with the rules. Alternatively, members, if they go to a few doctors in our country, do not take medical scheme, and sometimes a member may prefer to still go to these doctors, in which case you pay upfront and you claim according to our tariffs. We refund a member. The challenges that are generally faced by medical schemes is that medical schemes use what we call community rating, and it's basically or open enrollment. All medical schemes have to accept applicants and charge them the same monthly contribution based on the benefit plan that they choose, regardless of the age and their health status. And it's a noble idea. It is to ensure that there's cross-subsidization. The younger and the healthy must cross-subsidize the older and the sickly. However, as it is natural, people who are young and now not generally sick, they start saying, but why are we paying? They only want to join when they become sickly. But a medical aid has to build the pool and the reserves using the money of those that are still young and healthy until their time comes in the future. That's the concept of a medical scheme. We also have to maintain a reserve ratio of 25% solvency. And this is basically 25% of the calculated annual contribution income. So at the beginning of the year, the actuaries will say, the way you anticipate that you'll grow and the members that will be added by the end of the year, you will have received so much contribution income, and based on that, you must have a reserve of 25% of that. With big medical schemes like ourselves, that 25% tends to be overexpressed, if I can put it that way. And it is something that is being considered. We actually just talking with the regulator. This is a regulation in the Medical Schemes Act, and it has to be complied with. But there are views that maybe we should move to a different reserving strategy called risk-based capital, the one that is used by the insurance companies. Prescribed minimum benefits was also, it's part of the regulations of the medical scheme. All medical schemes registered in South Africa have to provide a set minimum of healthcare benefits. These are called PMBs. The scheme has to pay all of these at cost. This is to provide treatment and care in line with the Act, and to ensure that these chronic conditions and life-threatening illnesses, sometimes emergencies, have to be covered by medical schemes. Unfortunately, since the so-called reference price list, which was really regulating the prices that medical schemes pay to the doctors, and this was after a ruling, I think, in 2009, this issue of paying at cost has unfortunately been abused by our colleagues, healthcare providers, who are now charging above scheme rates, and it is driving the costs upwards. One of the topical things that generally is confusing in the medical schemes industry is the emergence of medical insurance products. And we thought we should just do a quick comparison. So a medical scheme is registered in terms of the Medical Schemes Act, as we have been saying. However, a medical insurance product is registered in terms of the Short-Term Insurance Act. The medical scheme is regulated by the Council for Medical Scheme. The short-term insurance by the Finances Conduct Fee FSCA, I think it's the FCSA. With regard to medical scheme, a medical scheme may not refuse members and discriminate against anyone, irrespective of their age, their status of health, as long as they can pay their monthly contributions. Whereas with insurance, they assess you first, and then if you are at high risk, they can say no. In terms of fees, medical schemes are not allowed to make a profit, whereas with insurance, they are allowed to make a profit. And the estimates, and I stress estimates, are that the claims ratios of insurance products are anywhere around 60%. They would obviously differ. And that means that about 40% of what these products, their income is basically profit. But this is based on its estimates just from what we know in the industry. With regard to claims, medical aids have to reimburse all actually medical expenses that are clinically necessary and appropriate. Whereas with products, it's basically a policy will just say, we will pay for these illnesses, we won't pay for these illnesses, so there may be exclusions. With medical schemes, hospital benefits are covered comprehensively, whereas with insurance products, the products can be, they come up with a package, and that package is what they will pay for if you have an hospital event, irrespective of what the needs are. As I've indicated earlier, medical schemes must provide full cover for PMBs conditions, whereas with insurance, there is no obligation to cover PMBs. The very same PMBs for what we call ambulatory care, that is care outside the hospital. For medical schemes, there are 26 conditions, sometimes people say 27, that have to be covered. And it is a list that is there in the medical schemes regulations. With an insurance product, there is no obligation to cover these. The GEMS leadership, the chair has indicated in the introductory remark that the oversight is from a board of trustees, and these are the board of trustees of GEMS as we speak today. Then we, as the executive management team, we are responsible for the day-to-day running, and then we report to the board based on the strategy that has been approved to implement the board's strategy. We run the scheme based on policies that have been approved by the scheme, and we account to the board. I am now going to hand over to my colleague, Dr. Vuyo, to take us through the next few slides.
Thank you, Dr. Stan. Good morning. If one of my colleagues could confirm if my video is visible.
You are visible. You can proceed. Thank you very much.
Thank you, Chairperson. Good morning, Honorable Chairperson of the Portfolio Committee, Honorable members of the Portfolio Committee, the Minister and Deputy Minister Public Service, the Board Chairperson of GEMS, as well as GEMS trustees, the Principal Officer, and my colleagues that are present, all protocols observed. Chairperson, I will be taking you through the GEMS operating model. As Dr. Stan has alluded to in his previous presentation, GEMS is a not-for-profit organization that is registered under the Medical Schemes Act, and it is a member-owned medical scheme. We operate on a strategically outsourced model to deliver the operational services like the payment of claims, hospital authorization, authorization for medicine, and matters of that nature. We have subcontracted several service providers that are called administrators of managed care companies that are also accredited by the Council of Medical Schemes to render some of these services. As I mentioned, it's the administration of member claims, the registration of membership. Managed care and clinical risk management refers to things like hospitalization, oncology, medication, chronic benefits, etc. And we also outsource call center and member services. While we operate on a primarily outsourced service model, we do have the capability internally as GEMS from a head office perspective, where some of the core strategic functions are managed internally. I'll just give an example. We manage our own tariff files. Masingita mentioned earlier that we also conduct our own tariff negotiations with hospital groups and pathology groups, for example. We develop our own alternative reimbursement models. We manage our product development and benefit design, as well as oversight of our finances. We've got a research unit that informs some of the work that we do. We also offer wellness services to members in the workplace, and we're also in the process of insourcing some of the core strategic initiatives at GEMS. So while we operate on an outsourced models with these service providers, there are certain functions that are managed internally through the scheme. We retain full strategic control through the Board of Trustees that is appointed in line with the Medical Schemes Act. The chairperson of GEMS mentioned earlier that our trustees are appointed, 6 of them are appointed by the employer, and the other 6 are elected by members of the scheme. We've got the principal officer who is supported by executive management to oversee all the strategic and operational administration affairs. And with regards to the service providers that we have outsourced to render the claims services, we maintain oversight, strict SLA management, as well as performance management. And we link these. There are certain performance management. It's not just about the SLAs in terms of call center services, but we focus on health outcomes. So these service providers are also monitored and managed with regards to how they are performing to improve the healthcare of our members. We also render independent audits, and these service providers, which we call SPNs, we also do the audits help us to also do some performance reviews. With regards to our non-healthcare expenditure, it used to be called non-healthcare expenditure, chairperson. Now it is called directly attributable insurance expenditure. What this means is basically the proportion of our revenue that we use on, or that we spend on non-healthcare costs. Non-healthcare costs would be, for example, paying some of the outsourced service providers. We remain one of the lowest in the industry. So if you compare GEMS to restricted and open medical schemes, our non-healthcare expenditure remains low. We are sitting at 3%, which is much lower than restricted schemes that are similar to us that sit at 4%, and while the open schemes sit at 9.5%. So this does indicate that this outsource model that we outsource to these for-profit entities are not necessarily expensive than the in-source services. And the results that I'm mentioning, or the stats that I'm mentioning, are from the latest Council of Medical Schemes annual report. Next slide, Dr. Stan, please. Chairperson, just a snapshot of a day in the life of GEMS. As it was mentioned earlier, we ensure close to 2.4 million public servants as well as their beneficiaries. So this is what what GEMS looks like. I'll run through some of the stats. On average, we handle over 1,800 call center calls per day. We also handle over 1,300 queries per day. These queries come through our various channels like social media, email, and call center. On average, Chair, there are 195 members that are registered on GEMS per day. These are the public servants. And these public servants come with 668 beneficiaries per day. We process over 160 million benefits per day. In terms of just some of the healthcare stats, on average, 65 new GEMS babies are born per day. We pay over 100 million rands per day on PMBs, which are prescribed minimum benefits, which are legislated benefits that every single medical scheme is required to pay by law. We also pay over 25 million rands in specialist claims alone. We authorize just under 1,500 admissions per day, and we process just under 400,000 claim lines per day. So this is just a snapshot of showing the operations at GEMS. Next slide, Dr. Stan. In terms of the challenges that are confronting GEMS and its members, it is very similar to the challenges that are faced by other medical schemes. The industry is faced with rising costs of healthcare, including new technology, including supply-induced demand. This is driven primarily by the fact that in the industry that we operate in, healthcare service providers, which is healthcare practitioners, can basically charge any tariff they want to. So, for example, a specialist may decide that while medical schemes on average will pay, let's say, 1,500 for a consultation, they can decide that they will charge 4,000 rands for one consultation, and this is unregulated. This is also one of the issues that were mentioned as a problem in the industry by the Health Market Inquiry. We also are faced with medical inflation that is rising above CPI. There's always new technologies in medicine that also cause escalating costs. And of course, we are faced with an aging population like any medical scheme. So the problem with an aging population is that we are faced with older members that are sicker. And the way any medical schemes work is that the young and the healthy cross-subsidize the old and the sick. What we tend to see is that younger members join a lot later in life because they really believe that they're healthy and they don't need medical aid until they get to a point where they start to get sick. So we are being faced with an aging population, and it does affect the cross-subsidization. We also are faced with fraud, waste, and abuse. This is something that is a big problem in the industry. Dr. Stan, towards the end of the presentation, will speak more on the fraud, waste, and abuse, as well as the findings of the Section 59 investigations. We also have problems where we have competing insurance products. These are short-term insurance products that are governed by the Short-Term Insurance Act. They are not subject to the Medical Schemes Act. Dr. Stan did go through the difference between medical schemes and insurance product earlier on. The CMS, Council of Medical Schemes, requires us to maintain a reserve ratio of 25%. This refers to the minimum solvency level that we are required to maintain, and it represents a proportion of our accumulated reserves relative to the annual contribution that we receive from our members. We are in the process of engaging the Council of Medical Schemes on looking at the regulation around the reserve ratio. It's called a risk-based approach, where we suggest that different schemes, for example, different schemes that are large like GEMS and Discovery, for example, may require different solvency levels versus smaller medical schemes. This is not legislated yet, but these are conversations that we continue to have with the Council of Medical Schemes. Chairperson, I'm going to hand over to our CFO, Ms. Karina van Lingen, to take us to the next phase of the presentation. Thank you.
Thank you, Dr. Vuyu. And good morning, Chairperson, committee members, Deputy Minister and Minister, board members, all protocol observed. Next slide, Dr. Stan. So many colleagues have touched already on the reserve ratio requirement for the scheme. So what we're illustrating here is GEMS came off a very high base of reserves post-COVID. And there was a deliberate decision taken to reduce the reserves to the level that is required in terms of the regulations of the Medical Schemes Act. And as you will note, that reduction has taken place now over the last couple of financial years, and we are now at the level of around 25%, which is the requirement. So the challenge would now be to maintain at this level, as these are the current regulations, but also bearing in mind the engagements that we are currently having with the regulator in terms of the risk-based capital model, which is applied in the insurance industry and indicates that potentially for a scheme as large as GEMS, 25% in reserves might not be the appropriate level and possibly a lower level. Next slide, please, Dr. Stan. So the scheme currently holds about 23 billion Rand in reserves. These funds are invested with our asset managers that we are showing here. And these asset managers manage these funds on behalf of members. These are members' funds. As was indicated earlier, the scheme and the funds belong to the members. And these asset managers ensure that these investments also result in good investment returns annually. That also supports the financial position of the scheme, and of course, in turn, then what members would realize at the end of the day in terms of contribution increases or better reserves. Next slide, please. One of the biggest challenges we have faced over the last couple of years, what we illustrate here, is what we refer to as the claims ratio. So this is by far the biggest expense within the scheme. What we pay claims towards, and you'll note the significant increase post-COVID that has continued. And these steep increases are largely due to the increasing burden of disease, fraud, waste, and abuse, which has also been mentioned, and supply-induced demand. So there's a big focus within the scheme at the moment to try and address these very high claim levels, as this is a consequence of the scheme potentially facing such challenges. And the main area of concern that we have seen on the next slide, Dr. Stan, is particularly at hospital admissions and the in-hospital associated costs. You'll note from this graph that the increases in these areas are far above what we had expected in the previous and the current financial years. So the focus is on this area. So this is the biggest challenge at the moment that the scheme is facing in terms of financial sustainability. However, if we go to the next slide, I think a term that is more frequently used in the market or within entities is the liquidity position of an organization. So this typically indicates the going concern matter or principle for companies, which states that you are able to pay all of your liabilities as they become due. So what we're reflecting here is on the last 2 financial years, the scheme's liquidity ratio being between 4 and 5, and of which the norm is 2. So normally in an organization, if your assets cover your liabilities at least 2 times, you are a going concern with no indication of financial hardship. So illustrating here that GEMS is far beyond the norm and very capable to pay all of its claims and liabilities as they become due. Next slide, please. So just a reflection on what we are forecasting for the end of this financial year. I think what is important to note here, if you look at the 3rd line from the top that says net claims incurred, what was budgeted and what is projected, we are projecting almost R1 billion more in claims in this financial year is what we expected. And as I've mentioned, this is the focus area of the scheme and one of the challenges that we are facing. However, at a bottom line level, we will still comply with the reserve requirements of 25%, and we are forecasting a slightly worse position than what we had budgeted, and that is mainly due to the higher claims experience. Next slide. So this is the last slide on the financial sustainability. So the scheme continues to prudently manage the finances. We have a robust benefit design process and a sound investment strategy to support the long-term sustainability of the scheme. And these efforts ensure that we continue to provide access to quality healthcare for our members with maintaining affordable contributions and preserving value for members. The scheme, we can confirm, remains financially sustainable in the long term. There are no concerns at this point in time. And the current performance in terms of the claims experience is a determinant of what the scheme pricing will be. And our pricing process that will commence shortly is then based on actuarial models and the results of the interventions that we have implemented at a claims level through the Claims Management Forum for 2025, which will then result in the outcome for 2026. Thank you, Dr. Stan.
Thank you, CFO. I will then, Chairperson, we're left with just about 10 slides or so. The next slides relate to what has been topical in the past 2 weeks. It has been a matter of public discourse. It is on the 7th, which was last Monday, the chairperson of the Section 59 investigation panel handed over the final report of that investigation to the Minister of Health. Immediately thereafter, the Minister of Health published or released the report to the public. So we basically are going to share basically what the GEMS position in relation to the outcome. So the investigation originated in 2019 after there were allegations by a group of healthcare practitioners that medical aids treated them unfairly on the basis of race. And this led to the launch of this investigation referred to as the Section 59 investigation. In the preliminary report that was released in 2021, the panel found that Black practitioners were more likely to be found to have committed fraud, waste, and abuse than their non-Black And non-black is used here for the purpose of description as per the entire investigation. And this was the finding against Discovery, Medical Medscheme, and GEMS ourselves, and based on data that they analyzed that we had shared as participants in the investigation. The data was from 2012 to 2019. May I state at this stage that it has been stressed that this was an inquisitory inquiry, not a judicial inquiry. And that is very important, how the findings are handled. The preliminary report said that there is no evidence for explicit and intended racial bias in the algorithms and the method that the administrators and the schemes used to identify. However, the panel found that the discrimination showed and was in the outcomes of the work performed. Now, there were recommendations coming out of this interim report. These were that schemes that are willing, these were recommendations that's why I'm using the term willing, should design policies drafted by a diverse grouping of people to remove implicit bias. We should research and monitoring. There should be a research and monitoring program that preempts and addresses racially skewed outcomes that were found in the data analysis annual. Then there should be an annual impact analysis of the fraud, waste, and abuse processes, and this should be submitted to the regulator. And then there was a recommendation also for an unconditional public apology. Now, then there was a lapse of that period between 2021 until, so that was in January 2021 when the interim report was released. The final report was released just over 4 years later, on Monday last week. In the final investigation report, the panel affirmed its analysis in the interim report on the far-reaching but procedural fairness in the implementation of the scheme fraud, waste, and view systems. Now, these are some of the statements that come out of the report that we thought would be relevant to just indicate where some of the findings. Having considered the subsequent submissions, so between 2021 and the release of the report, we made further submissions as required, as it was an opportunity given to the schemes and those that were mentioned in the interim report, we did so. The report, so these were considered in the time, this included the time lapse since the interim report, and there are other attendant matters that are in the details, but the panel confirmed its findings and recommendations from the interim report. The recommendations that came out of the final report are that schemes and administrators should develop an early warning systems whereby schemes notify providers as soon as schemes become aware of any circumstances which might lead to the application of Section 59.3 of the Act. And the Section 59.3 of the Act has to do with clawbacks, suspension of direct payments. All of that are the ones that they say if they are to be applied, there must be an early warning system to warn the affected healthcare providers. There's a need to review the audit and clawback time period. There ought to be a mechanism to assist providers in engaging the schemes once providers are accused of conduct which amounts to fraud, waste, and abuse. There must be a complete transparency regarding the software, the algorithms, and the artificial intelligence programs that the schemes use to monitor claims made by providers and members alike. So all those mechanisms that are used to identify possible claim. The CMS and stakeholders must abuse systems does not breach Section 9 of the Constitution and the provisions of the Equality Act. So when we read the report as GEMS, we basically got assured, and this is the statement that we have put out, that it is reassuring that the panel has found no evidence that GEMS acted with racist intent. And the underlining word is intent. This distinction is critical because the report says there are structural outcomes that show bias. We are of the view that these structural outcomes, they must not be confused with deliberate discrimination, which would be intentional. So we are basing this statement on the extract below, which we have copied as it is from the final report. And we think this is very important considering the public discourse around this report. The panel wishes to emphasize, and I quote, the panel wishes to emphasize that any finding relating to race discrimination and a recommendation based on this finding is not a finding that the scheme and administrators are racist. In the public domain, it appears that the concept of engaging in discrimination and being a racist are too easily conflated. The former, this which is engaging in discrimination, which may mean the fraud, waste, and abuse system produces a disparate outcome based on race, demonstrates that there are probably errors in the fraud, waste, and abuse systems which must be corrected. There are, in all likelihood, numerous systems in the world which would produce similar differential outcomes. And the purpose of the Constitution and those tasked with implementing it is to constantly strive to undo these unfair systems. It is rightly a work in progress which requires constant monitoring and vigilance. So the scheme notes that other affected parties have already come out with their varied position on the findings of the final report. We reiterated, GEMS, that we are continuously going to strive to strengthen trust, accountability, and fairness in the administration of member healthcare benefits that we are responsible for. We remain committed to implementing fraud, waste, and abuse systems that reflect transparency, equality, fairness towards healthcare providers and its members. And just to prove this, over the past 3 years after the release of the interim Section 59 investigations report, we immediately started taking comprehensive steps to strengthen our fraud, waste, and abuse management framework to eliminate potential for disparate outcomes as were mentioned in the interim report. We are also reaffirming our zero tolerance towards fraud, waste, and abuse for the benefit of GEMS members. We will continue to work closely, as the chairperson has indicated in her opening remarks, that we will work closely with the CMS, Section 59 experts. There was a specific Dr. Kimi who was mentioned as who was supporting the panel. The healthcare providers we have already done extensive engagements with over the past 3 years. In fact, if anything,
for years has finally arrived. According to documents confirmed by legal experts and diplomatic insiders, an international criminal court.
Okay, thank you. So we have started work. We have worked with healthcare providers and have had positive feedback from them, but we'll continue to work with them. We have to ensure that our fraud, waste, and abuse systems are transparent, they are fair, compliant to the laws of the Republic, as we have always done, but we will make enhancements based on the outcomes, based on what we see from the report. GEMS is committed to continuous improvement and to continue being the transformative medical scheme that we have always been. Chairperson, in summary of the whole presentation today, we have stated as our submission to the Portfolio Committee that access to healthcare is a basic human right that is enshrined in the Constitution. Our mission is to provide members with equitable access to affordable and comprehensive healthcare, promoting the health well-being of the GEMS members. We have a mandate to ensure that there's adequate provisioning of healthcare coverage to public service employees. Our strategic thrust is to be a strategic partner towards the realization of UHC. We are a restricted medical scheme for public service employees. We are governed by a board of trustees in terms of the Act, the rules, and we are regulated by the CMS. The board exercise oversight in accordance with Section 57 of the Medical Schemes Act. It is a 12-member board which is constituted in terms of the scheme rules, compliant with the Act. It is constituted by 6 employer-appointed trustees and 6 member elected trustees. Each trustee serves a 6-year renewable term. GEMS governance structures complies with the prescriptions of the Act. We have benefit actions that are aligned to our mandate, aimed at maintaining affordability, giving members variability based on their health needs. We are part of a society where we face the same challenges that are faced by the society, reflecting the economic pressures that the society has. We are a not-for-profit organization pooling funds to defray healthcare costs. GEMS is a critical and important organization, being the largest medical scheme in South Africa, paying in excess of 389 claims per day. We have committed to working closely with the regulator, and we're trying to meet the regulator when, based on what will happen in the next few weeks, we will start engagements. We'll reach out to the Section 59 experts, the healthcare providers. We have been engaging them very extensively already over the past 5 years. But the aim is to ensure that fraud, waste, and abuse systems continue to be there, but they have to be transparent. They have to be fair and compliant with all laws of the Republic of South Africa. And we will be taking a lot of guidance from the Section 59 report recommendations. Thank you, Chair.
Thank you very much, Chairperson of the Board, Dr. Tutu, and Principal Officer Malobi, and also the other presenters that was featured today. We really do welcome this presentation. All the presenters were really enthusiastic and I thought passionate about the work of GEMS, and it really is warmly welcomed, and I think it was a very thorough presentation that we have received today. There is no doubt to me that GEMS is vitally important, as has been said in this presentation, because it ensures that our public servants and their dependents have access to value for money medical care. And I really welcome the fact that GEMS goes the extra mile to give medical cover options, that they have these different tiers that give lower income members of the public service also an option and an access to affordable, valuable medical scheme. Before we move on to further deliberations from the other members of the committee, I would just like to bring to your attention a letter which, addressed to myself, was received from NEHAWU, which raises some concerns which I suspect GEMS is very much aware of, and I would just like to ask GEMS to respond after all of the other members have deliberated as well, to respond to these to the 2 or 3 basic comments that has been made by GEMS, by NEHAWU. So I'm just going to quote a small portion of the letter. NEHAWU says that GEMS is the largest closed medical aid scheme in South Africa, and over the past number of years, the functionality and structure of GEMS has deteriorated. So I'm quoting from their letter, and NEHAWU believes that this is a result of GEMS opting to outsource the administration of payments to providers for profit third party such as MedScheme. So NEHAWU believes that this has had an impact on the quality of services rendered to its members. And in this regard, NEHAWU has been engaging with their members on some of the challenges that they are facing, which is what they include exorbitant and illogical annual increases. And I think the annual increases really at the core of the issue that NEHAWU has. They note their specific concern over premium increase of 13.5% versus the industry of 10%. And they also claim that in 2023, the GEMS board held 52 meetings, which cost 14 million rand, and a cost they view as excessive. And they also mentioned that in contrast, the Discovery Board met 9 times with a remuneration cost of only 1.5 million. So just based on these concerns, NEHAWU has requested what they call a strategic turnaround plan to improve the administration and the management of the scheme. And I thought it was important to bring this in as part of the deliberations today. And I ask specifically from my side as well that there are comments made on the annual increase of the 13.5%. The board that English word, remuneration cost. And if GEMS agrees with NEHAWU that there needs to be a turnaround plan. So from my side, I think it's important that those important issues is part of the answers which is given. But with that being said, I will now give other members an opportunity to also ask questions and deliberate on the presentation which we've just seen. And I see Honorable Langa's hand is up already. Honorable Langa, you have the floor. Please proceed. Thank you.
Thank you very much, Chair, and greetings to the Honorable Minister, Honorable Committee members, GEMS leadership led by Dr. Stan. If I'm not mistaken, I think there's also the chairperson of the board and also the board members if they're present, and all protocol observed. Chair, I would like to request to switch off my video for connectivity purposes.
No problem, Honorable Langa.
Thank you very much, Chair. Let me also welcome the presentation as a very detailed presentation. Maybe one appreciates all the hard work behind it. And actually, today's presentation is exactly what I think we've been testing for as a committee, as it sheds light in so many and various aspects. And maybe having said that, I also hope Dr. Stan can realize that we were not being difficult, rather we're seeking detailed reflections. Having said that, Chair, I would like just to shoot straight to the questions as I have a few. Given that no explicit racial bias was found in the algorithms themselves, how do the schemes account for the racially skewed outcomes in FWA findings between Black and non-Black practitioners? What specific mechanisms have been introduced to ensure that future FWA audits do not result in disproportionate scrutiny or penalization of Black healthcare providers? How will schemes comply with the recommendation for an annual racial impact analysis of FWA systems, and who will oversee the accuracy and independence of this analysis? What steps have been taken since the interim report to redesign FWA policies with input from diverse stakeholders, as recommended by the panel? How will schemes ensure transparency regarding the algorithm and AI tools used to monitor provider claims? And are these systems independently audited for racial fairness? Given the acknowledgement that structural discrimination occurred, how will schemes differentiate between unintentional system bias and accountable outcomes for affected practitioners? What form will the proposed unconditional public apology take, and how will schemes ensure that it is meaningful to the practitioners affected by years of reputational and financial harm? Has there been progress in developing early warning systems to inform providers about potential FWA concerns before punitive action is taken, as recommended in the final report? What role will the Council for Medical Schemes play in enforcing compliance with the equality-related provisions of the Constitution and Equality Act in the design and implementation of FWA systems? Will affected healthcare professionals have recourse to redress or restitution mechanisms for potential career or earned income loss due to past flawed FWA processes? If so, how will this be administered? And the last one is on the investments, on fund managers. How do members benefit from returns on investment? And if maybe this could be elaborated through examples from previous years. Thank you very much, Chairperson.
Thank you very much for those valuable contributions, Honorable Langa. Honorable Kilise, please go ahead.
Thank you very much, Chairperson. Good morning, everyone. Chair, I just wanted to have the committee and everyone in the meeting see that it is indeed me, but I would request that I switch my video off.
Thank you. Please proceed.
Thank you very much, Chairperson. Allow me, Chair, first to wish the Deputy Minister, Pingikekana, a belated birthday. I hope she had a revolutionary one. DM, I wish you economic freedom in our lifetime. Chair, in my view, GEMS does not really address how the scheme ensures affordability for the lowest income public servant. I think it's fair to request a clearer plan of how to reduce the contributions for these members. I also notice how they boast about their low non-healthcare cost due to outsourcing. And I think you know where I'm going, because as the EFF, we are against outsourcing, because this is a model that may exploit workers, in these outsourced roles. But maybe if I go to the questions, Chair, my first question would be, I just want to know how are some of the public servants still unable to afford GEMS? Because I think in the letter that you mentioned that is written by NEHAWU, they also do argue that GEMS is unaffordable. I don't know if our understandings are the same, Chair. And I understand, because if you've got cleaners and teachers, and there's particularly cleaners who earn maybe 3.5 or 5,000 and still have to pay, let's say 1.2 for GEMS cover, it leaves them with a very little money for food and maybe the other things that they need to do. Dr. Stern, I think, mentions how how GEMS was initiated to accommodate, you know, the people who can't afford health care. So I'm interested to know how they maybe even ensure that the outsourced workers that they talk about, you know, are paid fair wages enough to afford any of their healthcare schemes. I don't know if it's possible, because then it won't be worth bragging about if you're saying you've got, you know, people that you employ but can't even or are not paid enough to even afford any of your packages. The doctor also mentions that the preliminary report suggests that Black doctors are unfairly accused of fraud, but it doesn't really say what GEMS is doing to fix their bias system. Because if you've got like African doctors that are rejected and you've got non-African surnames, you know, who can make identical claims and are paid, I don't think that is fair, Chair. So I think maybe the doctor and team can maybe clarify with us how they are fixing their bias in the system. And maybe the last issue for me, Chair, the GEMS team mentions how their reserves have got billions in reserves. I'm just wondering, why can't this money be used to lower the member cost or cover like more of the treatments? Because their reserves grew, and that's what they pointed out to us, but they still have members that are paying, which I think it is one of the things, again, I emphasize that NEHAWU is emphasizing that GEMS is unaffordable. So it is not as affordable as maybe they are trying to make us to believe, because the people who want to access it find it not easy to access. That will be all from me, Chairperson. Thank you very, very much.
Thank you very much, Honorable Kilise. I see Honorable Makunu's hand. Thank you very much.
Good day, Chairperson. Can you see me?
Not quite.
You can't see me.
No,
I don't know
can't.
what is happening. I don't know. But I'm trying to show myself so that you can see me.
There you go. Welcome. Good morning.
Good morning to you, and good morning to the esteemed members of the committee and the representatives from GEMS. Let me start by welcoming the presentation from GEMS. And Chairperson, may I ask you to switch off my video, please?
No problem.
Okay. So let me just go straight to the questions. I know there's a big challenge, Chairperson, in terms of exhausting funds early in the year. And that leads to employees either terminating their membership with GEMS or ended up losing employer contributions. At the same time, their health status is worsening, which impact negatively on the performance in their respective departments. So what measures can be taken to prevent members from exhausting their funds early in the year, and how can benefits be structured to better meet members' needs? Are there any plans or benefits that offer more flexible funding options or rollover benefits to avoid losing unused funds at the end of the year? Maybe in terms of the employer's contributions, how can employer contributions be structured to incentivize members to manage their healthcare funds effectively and avoid exhausting them early? Are there any options for employers to contribute more towards members' healthcare funds or provide additional benefits to support employees' health and well-being? Another question is how does GEMS compare to other medical schemes in terms of value for money, and what sets it apart from other schemes? What could be the best strategy to minimize fraudulent claims by both the service providers and members? How best can GEMS partner with HPCSA in dealing with fraudulent claims of service providers? What consequence management can be imposed by respective departments on members who have been found to have committed fraudulent activities using GEMS? The last question is, are there any specific initiatives or programs that GEMS has implemented to improve access to healthcare for employees in rural areas? Thank you so much, Chairperson.
Thank you very much, Honorable Mkunu. Honorable Tikana, please go ahead.
Thank you, Honorable Chairperson. A very good morning to all the members of the committee, the Deputy Minister, and the team led by the Chairperson of the Board of GEMS. I'll request that I switch off my video, Chair.
Please go ahead. Thank you.
Thank you, Chair. Chair, mine is very few, but I wanted to reiterate, Chair, the concern on the issue of outsourcing the services, Chair, which I believe generally it's a cry, and we've been raising that we must minimize outsourcing. And I don't know whether I've missed the cost, because we have to measure that with the costs which are paid to the providers who are doing the services of the being payment agencies of GEMS, if I will be correct, if I'm using that term, because we have to be taken through of the costs which are being paid there in for doing the services. Chair, I want to reiterate that. The second issue, Chair, which I would like to raise, Chair, considering that our public service is around 1.2 million, and GEMS is having a membership of 800,000 plus, and with the full understanding that the purpose of GEMS being established by Parliament was to cover the public servants in general. What are the strategies of GEMS or general plan of GEMS to reach out for other employees who seems not to have interest, or who might be members of other medical schemes with which they might have claims that GEMS might be expensive for them, or the issue that GEMS does not cover them as their payments they receive, so they are not being covered on the categories or on the schemes. And I think it should be a concern, the issue of funds which are being exhausted earlier, because other employees might terminate the GEMS as a scheme because they would see that they would have extra cash or can use if they cannot benefit for a quarter of a year or 4 months in a year, because the finances are exhausted. And I would like to understand how long is a waiting period for a member to benefit from GEMS after he has signed off to be a member. Also, if they can take us on the annual interest vis-a-vis the annual interest to a scheme vis-a-vis the normal annual interest, the percentage, because some employees would terminate the services of GEMS or their membership from GEMS because they would see if they receive their annual interests, they don't see any changes to their benefits, as we understand clearly the economic status of our country. I would so wish that the percentage increase would not mean that what they should have received through annual increase would go to GEMS. Those are my concerns, Chair. Thank you.
Thank you very much, Honorable Tikana. Members, with no other hands that I can see on the system, I will then hand over back to the leadership of GEMS to engage with the questions and the comments made by members. GEMS, you have the floor. Thank you.
Thank you, Honorable Chairperson. May I kindly request that, Chairperson, I then respond to the NEHAWU letter with your permission before I ask the executives also to come in.
Yes, absolutely. No, you can go ahead as you mentioned.
Okay, thank you, Honorable Chairperson. I had shown my face before, but I will show it briefly, and then Chairperson, may I kindly switch it off now, and then respond to the letter.
Yes, Chairperson, absolutely. Thank you.
Okay. In response to the Chairperson, to the letter, Honorable Chairperson, thank you for the opportunity that you've afforded us to respond to the letter, which actually raised concerns about GEMS. We summarize the contents of the letter. I would like to reiterate that GEMS is a non-profit organization. It is a restricted medical scheme, as I had alluded in my opening statement, and is for the public service employees. It is owned by the public service employees, and it is governed by a board of trustees under the Medical Schemes Act, and it is regulated by the Council for Medical Schemes. We are committed to the ethical governance, operational excellence, affordable, high-quality healthcare access, and access to over 2.4 million beneficiaries of the scheme. GEMS is a multi-administrator outsourced model which promotes efficiency, competition, and transformation. However, we must say that even though we are an outsourced model, some of the functions have already been insourced. Member and provider satisfaction remains very high, and our financials are stable with 19 consecutive unqualified audits and a AA+ financial strength rating by the rating agencies. In 2024, GEMS responded to an increased healthcare demand while maintaining reserves above the statutory requirements. Although the contribution increases of 13.4% were necessary, they were responsibly implemented to ensure that there is long-term sustainability of the scheme. We continue to engage unions and stakeholders constructively on the challenges that face the scheme. We do not share NEHAWU's view that a turnaround plan is needed. We welcome the ongoing dialogue with Labour, the Minister, and the Portfolio Committee on these challenges. And as the board, we remain committed in ensuring access to healthcare for members of the scheme, as it is their constitutional right. Our governance of GEMS remains centered on the mandate to provide equitable, affordable, and quality healthcare to all the public service employees. and to supporting the realization of the universal healthcare coverage. Chairperson. Let me go to the next one. Okay. The long version summarizing various points in NEHAWU letter to use during the deliberation. As we have indicated in the presentation, GEMS is restricted for non-profit. Regarding its governance and operations, it applies a strong ethical governance guided by King 4, Medical Schemes Act, and its internal board approved policies. The scheme uses a multi-administrator outsource model, as I have already alluded, and it promotes innovation and efficiency. It lowers non-healthcare costs. It drives transformation and service excellence. This model supports over 2.4 million, as we have already alluded to. And from a performance and member value perspective, the member satisfaction surveys remain at 80%, from a net promoter score of 88%. The healthcare provider satisfaction is equally strong at 87% overall. Our non-healthcare costs remain below the industry averages, showing strong cost efficiency. And I'm going to allow the PO to actually deliberate on this as well. GEMS has achieved 19 consecutive unqualified audits, and I've already said, as it pertains to financial sustainability and contribution increases. GEMS has responsibly managed contributions while protecting member value. At 13.4% in 2025, we feel that as GEMS, it was necessary to maintain the scheme's solvency and compliance with the 25% reserve ratio requirement. 25% reserve ratio is a statutory requirement which is regulated by the Council for Medical Schemes. And as of the 31st of March 2025, the reserve ratio was sitting at 27.04%. We are committed to continued engagements with Labour as an important GEMS stakeholder. GEMS regularly engages with Labour unions, including NEHAWU, through the PSCBC and bilateral meetings. While we acknowledge NEHAWU's concerns, we do not agree that the strategic turnaround is really necessary. And in closing, GEMS is committed to providing an equitable and affordable healthcare to public servants, upholding sound governance and sustainability, contributing to the realization of the universal healthcare coverage. And we remain available for continued engagements with the Honorable Minister of Labour, the Portfolio Committee, our own Minister, to ensure that the transparency and that progress be made on the challenges that have been identified. Thank you, Honorable Chairperson. I'm going to hand over to Dr. Stan and his team. Over to you, Dr. Stan.
Thank you, Chair. Can I thank you, Chairperson, Mr. De Villiers, Chairperson of the committee. We have been asked several questions. I will start with where Mr. Langa, Honorable Langa, started. I am going to, along the way, my colleagues will, in their various elements of areas that we are responsible for, and it will not only be me. I will somewhere along ask my colleagues just to chip in. I will indicate to them as I go along. So but I think mine is stable, but I'll also just request if I can talk also having switched off.
No problem, thank you.
Thank you. The first question was related, and there were several questions, and Honorable Langa, please, you were going a bit fast, and if we missed anything, can I request you, please, you can refer us back, the chairperson allowing. So you indicated as a preamble, and we thank you that you welcomed our presentation. And you indicated that the outcome, the Section 59 fine report showed that there is no explicit racial bias. However, it does find that in the outcomes, there are indications that our processes may be showing bias in how we deal with the healthcare provider. So basically your question was, how do we account for that? So as I indicated, as we are aware, we are worried, and the industry is always worried. The estimated fraud that may be committed, and we don't have exact numbers in South Africa, but it is estimated that fraud could account for 5 to 15% of what the funding industry pays. Now, we then say, if it is estimated that it's anything between 5 and 15%, let's take the middle of those two extremes, then it's 10%. So if we use GEMS in 20, in excess of 60 billion rands to healthcare providers, all of them, individual doctors, allied health professionals, hospitals, pharmacists, all of them. If that figure of 10% could be paid to fraud, it means that 6 billion was paid to fraudulent claims, because people who are fraudulent, those who are fraudulent, and I did indicate earlier when I presented, there was where I was showing that a third-party payer system is what makes fraud possible. So 6 billion could be fraud. It's a lot of money. So it is not something that can just be ignored, and hence there are methods to try and overcome fraud. However, it is natural that when you are subjected based on certain things that we identify that this could be cleverly, it is natural that anybody will come up with ways of saying, I'm a victim, I've been run wrong. So that is what we are faced with, and the scheme is basically using the best possible systems that are available to us to try and prevent fraud. So that's and the question was, how do you account for this? And I was just basically saying it happens in the way we are trying to fight fraud. However, we noted the outcomes of the final report. And your next question was that how will we prevent these outcomes in future? We have committed as GEMS that we will work with, now that the report is out, we are still waiting. The Council for Medical Schemes, who are the owners of this investigation, has indicated they are still going to look at and decide. There's been a lot of public discourse. The Minister of Health is the responsible minister for the health funding industry, regulating it via the Council for Medical Schemes, and they have indicated that they are still looking at what will be next. Usually, investigations by the Council I'm saying usually, I'm not saying that's going to happen. The Council for Medical Scheme may decide to come up with directives, and we will wait for that. We will also, as we indicated in the presentation, we are seeking to meet with the Council for Medical Scheme so that we can establish the expectations and as part of our response to the release of the report. The next question was, what steps have been taken since the interim report, since the interim report? So we've indicated that, and it is there we have released two statements since the report was released, two media statements just to indicate our position. And in this, we are saying we have already implemented the recommendations that came out of the interim report. And when you look at the recommendations from the final report, there's similarities. So we actually have already implemented some of the things that came. There are are similar. So we'll continue to do that. There was a question, how will the scheme differentiate whether it's still being biased against Black health professionals, if I caught that question well. And I think just from the beginning, we have indicated that our systems were not really based on identifying the surnames, because it is one of the things what in our secondary submissions to the panel were that we don't identify doctors, healthcare providers, whether they are Black or white. In our claims, we have what we call the PCNS. The PCNS is the practice coding numbering system, which practices used to submit. However, the methodology that was used by the panel expert was that they used surnames to say this is Black, this is non-Black, and we had a problem with that. However, the intention of GEMS is not to start challenging. We've taken a position that we need to deal with this issue. It is one of the things that we want should be behind the industry. So behind us, it should pass. It cannot be that we can be living under this cloud of there is discrimination against Black doctors. So we will do everything that we address anything that comes out of the report. And the GEMS is not saying we did wrong, and I'm addressing the next question. How will the public apology be undertaken? Actually, it has a recommendation from the interim report. It is very difficult to apologize if you don't believe you have done anything wrong. And so while we noted that there was a request for a public apology, GEMS did not come public with that. And we thought we should basically just wait for the final report and deal with the issues. So that was the question, and that is what we have done thus far. Is there any progress in implementing the recommendations? As we have indicated, the interim recommendations have been dealt with, but it is a continuous process. We are looking at what is it that has come out of the final report and that we may need to look at. Will affected health professionals have recourse on how will this be administered by GEMS? I've indicated during the presentation, this Section 59 investigation was an inquisitory investigation by the Council for Medical Scheme using eminent legal persons. They have made recommendations, and I've read a statement from our presentation that basically says the public discourse is actually conflating issues. GEMS will wait and see. We already have one political party that has actually opened criminal cases, but the report does not say there was criminality. And it is unfortunate that we may find ourselves having to deal with legal issues, whereas we want to correct what this whole episode may have revealed in the industry. So GEMS will continue as an organization, respond to any of the legal issues that may arise out of this and deal with them. Thank you very much. Can I ask CFO, the next question was on investment. It was an investment question. May I ask if you caught it, if you can assist with that?
Thank you, Dr. Stan. Yes, I'll assist with that question. So how does members benefit from investment returns? So I think the easiest, as you have mentioned, is to give a practical example. So in the last financial year, the investment income achieved for the scheme was about 1.7 billion more than what we expected, and that was due to the way we invested these funds. And that in turn for the member reduces the contribution increase between 1.5% to 2%. So essentially what it means is if we didn't have that investment income in 2024, the 13.4% would have been even higher. So that is the benefit that members receive from investing these funds. While I'm on that point, Dr. Stan, if you and the chairperson will allow me to share, I can address then the question on using reserves and the contribution increases over time. I have two slides that I would like to share, then we can deal with that matter. Let me just see if I have sharing rights. I don't have sharing rights, unfortunately. I'm not sure if I can obtain those, otherwise I can just speak to the information.
Yeah. Can I, Chairperson, I don't know, we need assistance with sharing rights. We're not sure the administrator.
Masi, can you please assist the CFO with sharing rights?
Yes, Chair, they can proceed. Thank you.
Thank you very much. So on this slide, I'll just put it on presentation mode. These are the contribution increases the scheme had implemented since 2019. Now, you will note 2019 to 2020 and the beginning of 2021, these contribution increases were relatively close to your average healthcare inflation, which is the red line. Then, due to the COVID pandemic and the hardships that our members experienced and the economic climate, there was a big drive to support
Sorry, Karina.
Please switch off
your camera.
2022 to 2024. See, we implemented it. Yes. Okay. Should I repeat?
Yes, please. I think if you don't mind just starting again, you broke up as you started with the presentation, but you are now audible.
Sure. Thank you, Chairperson. So what we are showing on this slide is the contribution increases for the scheme over time from 2019 up until 2025. And you will note 2019 to healthcare inflation, which is the red line illustrated on the graph. As we know that healthcare inflation is above CPI, and therefore medical schemes usually have to increase contributions close to healthcare inflation. So due to the COVID pandemic and the hardship that our members experienced, there was a deliberate decision taken by the Board of Trustees to assist members in 2022, 2023, and 2024 with very low contribution increases. Due to the economic climate we found ourselves in, many members, family members, didn't have work to go to, etc. So that was a deliberate decision by the board. And how did we do that? We did that by using the reserves, which was also a previous question. We used the scheme's reserves that were built up over time, and particularly through the COVID pandemic, to use those funds to support members in those years. Now, what that does is once you implement contribution increases below inflation and even below healthcare inflation, it reduces the reserves because essentially the scheme is paying that part of the contribution for members. But what it does is it reduces reserves to a level where we now have to maintain a specific level of reserves, which is the 25% we've spoken about. And in order to do so, the contribution increase of 13.4% for 2025 was to ensure we now normalize and maintain the 25% contribution, 25% reserve ratio. And you would note from this slide also that since 2022, the scheme has used 10 billion Rand to support members in lowering contributions. Thank you, Chair and Dr. Stan. I think that addresses 2 or 3 of the questions asked in that regard.
Okay, thank you. Chair? Chairperson?
Yes.
We still have a few questions. You'll continue to guide us on time and all those. So we are now on the questions that were asked by Honorable Guguleti. No, I think. Honorable Khelishe. Can I just quickly round them up because there's 3 parts to the questions. Firstly,
CEO Malobi, I just want to say that we are scheduled to go until 1 o'clock, so you still have more than enough time to adequately answer the questions, please.
Thank you very much. So the preamble by Honorable Khelishe, and I hope I'm saying it properly, is that GEMS does not show how it is making itself to be affordable to particularly low-earning public service employees. Now, actually, there are, and that is why we have client liaison officers, and we also have a dedicated service that advises. So our client liaison officers will take up a problem. If they are at either a servicing point or any of our events, or they are at a pay point, we have offices of our CLOs throughout the 9 provinces. They service members from the workplace, so they respond to various. And what they do, if a person maybe joins government and we are called upon to go and inform them about GEMS, we basically explain how the subsidy works. And the information is very important that our lowest earning public service employees are able to go on to Tanzanite 1, and depending on how many beneficiaries they put on the scheme, they actually can join the scheme without paying a cent. And this is some of the information that maybe sometimes it's not well understood. And so we still believe, and actually we know that, and I'm being very careful here when I say we know, because I don't want us to sound like we are basically just answering. It is a fact that there are low-income earning public service employees who can be on GEMS with either zero or even minimal paying out of their pocket, with the subsidy covering most of what they are supposed to pay. But there is a factor also of how many beneficiaries they put on. There are other things that relate to sometimes members. As an example, a member joins GEMS on a lower options, they hardly pay anything. They tend to be, it's a member who happens to be very sick. They go to the doctors use a lot of investigations, and there's lapse, the benefits run out. In fact, we find that then suddenly a member who would otherwise not be using these services uses them. And if we don't pay fully because of exhausted benefits, they are faced with these accounts. And it's one of the things, it's a disadvantage. A member could, then some of them, they say, if I didn't have a medical aid, I wouldn't have this type of thing. So that is basically one of the biggest problems. So GEMS is still affordable, and one of the later questions is, how do we compare with other medical schemes? We do an annual comparison, and from the last report, we're about 25% cheaper than other schemes that are comparable. So, but you have to compare option by option. So we choose the options that look like the ones GEMS has, and came up with around 25% cheaper. And CFO, I need your confirmation. And then is it about 67% cheaper if the subsidy is brought in?
Yes, Dr. Stan, that's correct. So 25% more value for money before the subsidy and 67% more value for money once the subsidy is considered.
Thank you very much. And then there was a question thank you very much, from Honorable Felicia about outsourcing. And I just want to explain that our outsourced model COO, please add to what I'm going to say. Our outsourced model is not GEMS is not a fully outsourced entity. In fact, GEMS started as an organization which employed about less than 10 employees around 2006. It now employs almost 500 employees because it has been insourcing some of the functions. So all corporate services of GEMS are mainly insourced. We have, initially when GEMS was still growing, we used to have outsourced security services. Those are fully insourced. We used to have our cleaning staff and support staff for maintenance outsourced. All of them are now employed by GEMS. We have insourced. We used to have our finance function outsourced at the beginning. It is fully insourced, except for the processing of claims. And then there's a message that there's an instruction that, that comes to us and then we pay. So we're almost fully insourced on finance, except for just the processing of claims. That's the only part that's outsourced. And then we have functions like HR. At the beginning, they were outsourced. They're insourced. So all our corporate services, the only services that really are still outsourced because of what it would take to insource, and the scheme has been looking at this in terms of the strategy from 2017, is the member-facing services. So these are payment of claims, dealing with our call centers, and basically managed care services. So, and there is a program that is under the leadership of our COO. Dr. Voy, I don't know if you can just summarize the intent of the insourcing of capabilities.
Thank you. Through you, Chairperson.
Yes, please proceed. Thank you.
Chairperson, with your indulgence, I would like to share a slide just to show the insourcing journey that we've been embarking on for quite some time. I trust that the slide that I'm showing is visible.
We are not seeing the slide. Okay, it's starting to screen share. We're still waiting for the slides to just show. There we go. We can see your slides. Thank you, Doctor.
Thank you, Chairperson. I'm trying to put it in presentation mode so that it's more visible. And I'll just switch off my video so that I don't get any interference, Chair.
Yes.
So, Dr. Stan has mentioned that GEMS, when we talk about outsourced services, we talk about primarily the administrative services like call centers, pre-authorization, and processing of claims. And these are outsourced. It can only be outsourced to accredited administrators. There was a mention of MedScheme before in the NEHAWU letters. MedScheme is an example of an accredited managed healthcare company that operates as an accredited company that operates in line with, I think, legislation in terms of providing employees with sufficient cover. But when we talk about I'm just going to go through, Chairperson, very briefly. I'm not going to take too much time. I think I just wanted to show the progression of the insourcing of the GEMS services, starting way back from 2014, where we insourced internal audit, ICT, corporate services. We also started the management of our healthcare networks. We pre-2024 have always negotiated our own tariffs, as I mentioned earlier, implementing alternative reimbursement models as well. So tariff negotiations are annual negotiations that we do with all the hospitals and pathology labs that we negotiate with. Over the years, then we started establishing, for example, the Emerald Value option was mentioned, and the GEMS hospital network. These are all things that were actually established from GEMS. We started also expanding on value-based care purchasing, which means we focus on incentivizing healthcare providers for better outcomes. So we don't just pay doctors, for example, for seeing patients. We incentivize them to make sure that members are healthier. So the healthier your patients are, the more we incentivize you to pay. This encourages better health outcomes. Then over the years, we've progressively insourced a whole lot of services, health and screening, security, health and wellness services, security services, cleaning services, as Dr. Stan mentioned. We built our internal capabilities of provider liaison officers. These are GEMS representatives that engage with doctors at their offices to educate them about the GEMS network, as well as the benefit offering. We started clustering managed care services to improve our efficiencies. We have gone also to look at the landscape and see other functions that we will be able to insource or co-source, like actuarial services, healthcare analytics, telemarketing services. And we are also, this is what we are working on now as part of our 2024 to 2026 strategy, is to look at other areas of insourcing, including an integrated call center that will be linked to some of our service providers, walk-in centers as well, also insourcing more of our network management. So GEMS is not like a typical, I guess, non-profit medical scheme that outsources all of its business. And by outsourcing, as you mentioned, we don't mean the security and cleaning services, but we mean the administrative parts of the work that we do. We are very intricately involved, and this is why there also has been a growth in the scheme over the years, to make sure that we continuously insource various services in the managed care and administrative environment. Chairperson, I hope this does cover the question. Dr. Stan, I'm not sure if I've left anything out.
No, thank you. I think you have addressed. Thank you, Dr. Voyo. Chairperson, the next question from Ms. Felicia was really the Section 59 report, which I think was covered in my answers to what Honorable Langa said. So we are working, just to emphasize that we will be working to this systems-related bias that is being spoken about. We have what you call a claims risk forum, where we interact with industry, and then we are also part of the Fraud, Waste and Abuse Forum by the Council for Medical Schemes. These are the platforms that we will participate in to ensure that we are part of addressing what Advocate Ngatobi and his panel came up with. So we are being very proactive. I think it's an important thing that the position of GEMS is that it wants to move on, and hopefully this thing can be, it is a system-related thing, and we basically are saying we want to be proactive in being part of the solution. The next question was that billions in reserves, why are these not used to lower GEMS? I think our CFO has dealt with how reserves have been used to help members. Honorable Nkunu, my tongue always struggles here, spoke to challenges relating to exhaustion of funds during the year, which can lead to members terminating. So why are there no rollovers? So there is only one type of a benefit option that a member who is on a medical scheme can choose and have rollovers, and it's called a savings plan. If you are on a savings plan, your day-to-day, that is your GP, your primary health care, some of things like your pharmacy costs for over-the-counter medicines. So there are certain defined things at the primary health care level that are paid out of a savings account if you choose that option. If you have an option that is a savings account, the saving account that is not used during this year will roll over to the next year. So with GEMS, we have one of the options has got rollovers. The rest of the options that we have on GEMS is that these fees are pooled, and it is not a money that is saved. And I really want to explain this, and I think this is important. If you belong to a medical scheme and it's not a savings option, you don't pay contributions and save money to use when you have a healthcare event. It wouldn't work. You buy a benefit that covers you for whatever can happen to you. And why is this important? Let's assume your contribution is 5,000 a month. You're going to contribute 60,000 for the year. But if you end in ICU, you're going to pay hundreds of thousands of rands. That money comes from the pool. So the various exhaustion of fees is because that benefit that you have used it because of your healthcare needs. And that is why on a year-to-year basis, you need to check and say, well, I had little benefits for this and I used it a lot. Maybe I should change to an option that has got more benefits. So it is usually one of the difficult areas that are not so well understood. And we try to understand, I explain this to members. So that is really how a medical aid works. And we hope that if people could understand how it works, it will help us to narrow what some people call the expectation gap, not the technical accounting expectation gap, but the expectation gap where a person says, I've got a medical scheme, and then they think they can go to the doctor 50 times at the GP level. It's not like that. Everything has got restrictions so that we are able to manage it. And this is really what we try to teach our members. How can GEMS partner with the HPCSA for consequence management of healthcare care? Yes, it's a very complex, but what we do is that if we reach a stage where we have proven that there was wrongdoing, we are obliged in terms of our rules to report health. But this is only done when there has been proof. We have, through our investigations, proven wrongdoing. So there is, we do report to the relevant regulatory board. Then Honorary Tikana Hotiwe, we reiterated the concern on the outsourced model, and I think we have explained, and I hope we are not doing crime because you said outsourcing is a crime. Our explanation is that we're doing everything to only outsource those things like Dr. Vuya indicated, where because we are not a self-administered scheme, these have to be done by accredited services as required by the regulator. However, there is an insourcing of capabilities program that she spoke to. So considering that the public service has around 1.2 million employees, and GEMS has just over 880,000 members. What is the plan to reach out to those that are not on the scheme? Can I point out that out of the 1.2, some of them are spouse. So we also have couple members. So you may find that if it's a couple, we have the principal member and then the spouse is a member. And that would then account for some of those numbers, the 1.2. There is, we do, and Malinda is in here, we monitor and check in the public service those legible members that are not on GEMS and are on other medical scheme. We try to indicate to them what would be the benefit, and the biggest benefit is the value for money that we spoke about earlier. But sometimes people still prefer to belong to the medical schemes that they've been with over the years, especially if they've never had problems. Medical scheme can make you to become loyal, but medical schemes also are like so year to year, your benefits are based on years. But I think in a sense, there are still people, but it's a smaller number who prefer not to be on GEMS. With regard to waiting periods, in 2017, we experienced one of our worst times in terms of the reserves that we are showing. GEMS had reserves of around 7%. The scheme was growing fast, and we were of the view that the reserves were fairly low because of the growth. However, when we did a deeper check, we realized that it is because we are not underwriting at all, trying to encourage access to health. And there was a lot of anti-selection. And anti-selection simply means people who'd come on, they claim, and then they leave. When they have a healthcare need, they come, they claim, they leave. And that is what led to the scheme applying waiting periods as outlined in the Act. And there are two main types of waiting periods. There's condition-specific waiting period, which simply means if you already have a condition, you have to wait for about a year before we can cover you. But if it's a PMB, the wait could be three months. And then a general waiting period can be applied up to 3 months. And then each and every case is assessed on a case-by-case basis. And this is answering what are the waiting periods. These are important to protect the scheme against what I've referred to as anti-selection. And then I note that there was a question from Honorable Tikana that we need to explain the annual increase more, especially where there is a perception that the member salaries are adjusted by a certain percentage that has been agreed in the negotiations. And then you find that if the salary increases for the year are going to be something like, and there's more to this, what I'm going to say. But a perception is that, let's say the salary increase that is implemented as agreed at the negotiations is 7%. And that 7% is 7% of the entire salary. But if GEMS comes up with any annual increase that is above the 7%, and this is only on the portion of the medical scheme, but the perception is that GEMS then takes away all the increases that the members have gained in the negotiations, particularly by labor unions. We are trying to explain, we explain in our meetings with the Public Service Bargaining Council that the explanation is a bit more, but I think we are sensitive. We are sensitive as GEMS that ideally we would love to have those, what the CFO was showing, where increases are closely aligned with MPI, Medical Price Index. But we have a situation where, because of the utilization that is higher than budget that we are experiencing from our members, the increases tend to be higher. And this is something that we are working hard to overcome, and we need the assistance of all our stakeholders to change the claiming patterns of our members without restricting clinically appropriate care that we will always want to pay for. Thank you, Chair.
Thank you very much. Members, that has indeed been a very broad and good feedback. I see two more hands on the platform. Honorable Langa would like to ask a follow-up question. And Dr. Vuyo has also put up her hand. I think she wants to maybe just add to what was said. Dr. Vuyo, I think I'm just going to give you an opportunity to quickly talk, and then I will give all members, including Honorable Langa, an opportunity for second bite at the cherry. Dr. Vuyo?
Thank you very much, Chair. I just wanted to add, because this and just to add to what my colleagues have already said, in terms of benefit depletion and affordability. Chairperson, as far as GEMS members are concerned, the analysis that we've done is that only about 5% of GEMS members would actually run out of benefits, usually by August, September. And how we assist those members to manage, the healthcare expenses is through what we call ex gratia funding. Ex gratia funding is not a benefit entitlement. It is grace funding that the scheme extends to its members. We always encourage members that are unable to, or that have run out of benefits, that need help, to apply for ex gratia benefits. Just to give an idea, Chair, in one quarter we process over 2,500 ex gratia applications, and we help members in one quarter with about 90 million additional assistance for anything that they need from their medical expenses. So this is any short payment, let's say from doctor consultations or from pathology tests that were done. It could be medicine limits that have been exhausted. This is what we do. So these are retrospective. Over and above that, Chair, we have what we call ratifications from an ex gratia perspective. These are urgent cases that we actually turn around within 48 hours. A typical example is a member that requires urgent oncology medication and their benefits are depleted. We offer this benefit, Chair, and we do a turnaround time of 48 hours. There's various other biologics and very expensive medications, some that may not be covered through our funding protocols. And typically over and above the almost 90 million we spent on the applications. With the ratifications from ex gratia, Chair, it's about 40 million per quarter that we pay over and above. I do need to stress that this is just as a way of assisting our members to make sure that should the benefits be depleted, this is what is available to them, and it's over and above the benefit entitlement. We also assist members by educating them in terms of how to avoid co-payments. We are contracted to various healthcare providers where they are obligated to charge the agreed rate, and this helps us in terms of protecting members against out-of-pocket payments. We also educate members on the importance of using generic medication, and there's various other ways in terms of, or for example, if you have a chronic condition, members are encouraged to please register for the chronic benefits so that they can unlock additional benefits so that they avoid using their day-to-day benefits. These are just some of the examples, Chair, and then just briefly on other value add. Why is GEMS? What is the value add that GEMS does compared to other schemes? My colleagues have mentioned the affordability factor. I just want to also add, Chairperson, that GEMS, unlike other medical schemes, has a very wide definition of what a beneficiary is. So a public servant can include as their beneficiaries their children and spouses, but we understand the typical African family extends to grandmothers, grandfathers, nieces, and nephews. So we've got a very broad definition of what a beneficiary is to assist our public servants to take care of people that are financially dependent on them, not just their children and spouses, but also their extended family. Thank you, Chair.
Thank you very much. Honorable Langa, please proceed.
Thank you very much, Chair, for another bite. Maybe, Chair, I think I have quite a number of follow-up questions, but however, in the interest of time, I think I will just reduce them and maybe focus on only the two on the presentation of the CFO. Maybe CFO, if you can provide clarity as in of the 6 fund managers that are reflecting, or rather that reflected on your presentation, is there a black-owned fund manager of those 6 that are there in the reflected on your presentation? And also, what informs the gap? For example, if you check this prescient, I don't know if I'm pronouncing it right, there's prescient on top with 37.88, then you have just under that Stanlip with 36.8, then it goes down to Coronation. That I would like to believe they've been good fund managers. They've been in the space for some time, but they're sitting on 13.74. And then it goes down to Cash and Cash, and then Taquanta, then 91. So maybe if I can check the CFO with what informs those percentages and that gap with those fund managers. Thank you very much, Chair.
Thank you very much, Honorable Langa. I see Honorable Tikana and Honorable Malinga's hands as well. We still have 8 minutes to 1 o'clock. So members, if you don't mind me just asking that you are brief and to the point in your additional questions. Thank you.
Thanks, Chair. Mine is not a question, but to correct the misquotation. I never said there's a corruption in outsourcing or criminality in outsourcing, but I said it's something which we don't want to be done. That's what I said in the meeting. If I said so, I withdraw. But what is my understanding on what I'm saying? I said we don't want outsourcing. We want it to be limited if it can be done for the services where employees cannot discharge those services. Thanks, Chair.
Thank you very much, Honorable Tikana. That is duly noted. Honorable Malinga.
Thank you, Chair. Firstly, let me apologize. I'm using the cell phone, so bear with me. I'm a BPT person. I was born before technology. So this thing of settings, it will take me the whole day or 3 days. So bear with me while members, they don't see my face. But the questions, it's 2 questions, Chairperson, for the time constraint. One will be, in terms of the outsourcing, is there any consultation that took place for the members to understand through the trustees, as I've heard that there are trustees in the medical aid? The second one is that the emerald option, I've seen that an individual member, they do have 2,700 rand per annum. The last one is that the barrel option prescription, it doesn't covered by the medical aid. Can they explain to me why?
We seem to have lost Honorable Malinga, or maybe that was just the end. Honorable Malinga, are you still there, or was that all the questions?
Yes, I'm still there, Chair. You've lost me.
Yes, we just lost the last 10 seconds. If you can just repeat, if you don't mind.
You never heard the whole question or the last one?
Just the last one, please. Thank you.
Okay, the last one was the barrel option at GEMS, the prescription medication is not covered by the medical aid. I just want the clarity on that one. Thank you.
Thank you very much, Honorable Malinga. If I can ask GEMS, we still have 5 minutes left on our schedule before I have to close the meeting. So if you can just be brief and to the point with your answers to these additional questions. Thank you.
Thank you. Dr. Vuyo, can you assist with the barrel? I'm not so sure barrel does not pay for prescription medication. Please assist with that one.
Yes, I will, Dr. Stan. I'll also take the EVO one, Emerald Value option. I'm happy maybe to take it offline because I think it may need some time, but I can confirm that the barrel option does cover in and out of hospital care, including prescription medication. So I'm not sure if I can provide clarity or if I can get more information from the honorable member on that. The Emerald Value option having only 2,700 per member, I am not sure whether this is for which benefit it is because there are various benefit limits. But certainly the Emerald Value option is not only restricted to 2,700. I think this may refer to the day-to-day benefits because the over annual limit is unlimited. All PMBs are covered, all chronic conditions are covered, and there's unlimited benefits for PMB conditions that are chronic. There's various sub-limits for various things like optometry, dentistry, and consultation and additional cover for extender benefits if the day-to-day benefits are restricted. So maybe the 2,500 means just day-to-day. That would really be for anything for over-the-counter medication or pathology tests, for example, Chairperson. I hope I've covered that, but I can confirm that we do cover prescription medication. And what I've mentioned for the Emerald Value applies to all other options. Of course, the higher end options will have larger benefit limits. The lower end options will not. But I do confirm that Beryl and Tanzanite One have got quite comprehensive primary healthcare benefits because they are meant for the lower income members and they focus on primary health care. Thank you, Chair.
Chairperson?
Yes, please proceed.
Yeah. I ask, I know we're left with our CFO just to answer on the fund managers.
Thank you.
Thank you, Chairperson. Thank you, Dr. Stan. So the first question on the black ownership. So all of our asset managers are level triple BE level 1. When these contracts are awarded through a tender, open tender process, there's specific evaluation criteria and scoring done in terms of black ownership and in particular black women ownership. And that is part of the broader GEMS triple BE strategy that is applied through our procurement processes. These asset managers also have a contractual clause where they are required to demonstrate annually how they enhance and support the development of specifically black asset managers in the industry. And those reports are given to our Finance and Investment Committee once a year. In terms of the gap between the asset managers, So this is due to the diversification of our investment portfolio and strategy to ensure that you don't have a number of asset managers that have the same investment philosophy and also the same type of structure of investment. So for example, the enhanced income is done by Coronation, and that is really, so the investment is limited to certain areas of investment where, for example, Prudential is one of our absolute return portfolios. So those are the more complex structures where we invest in equities and those type of things. And in order to achieve our investment strategy at the end of the year, these portfolios, in terms of the absolute managers, obtain more of the funds because the returns on those funds are potentially higher than what we would achieve just on a normal money market or enhanced income fund. Thank you, Chair.
Thank you very much for the feedback. Honorable Malinga and Honorable Langa, I see your hands are both still up. I'm not sure if those are legacy hands. Honorable Langa, legacy hand?
No, Chair. Maybe this question we can defer it, or maybe on the next quarter, or maybe when we meet with James again, because I'm not quite happy with the responses in terms of the companies that are complying through the BEE and black-owned companies, because those are two different things. So it can't be right that you get most contributions from, in particular, black people in the country, and there is no black company, solely black-owned company, that is given a chance as well to advance its knowledge or on the asset management side. But I'm not expecting a response now. I'm just saying I was quite not satisfied with the response. And also in terms of what informs the percentages that in terms of the contribution by the GEMS that they give to asset managers for fund managing. But thank you, Chair.
No, thank you, Honorable Langa. Your opinion is noted, and I think it is maybe something for James to reflect on, and we can have a potential discussion on it again when we have our next engagement. We have now reached. I see there is
DM Kikana.
Deputy Minister, please go ahead.
Yeah, no, I was saying, let's allow the question to be work in progress. James can be able to come back to the portfolio committee just to update you on how broad they are in empowerment and other related things. So yeah, it can stand over, and I know portfolio committee process also allow that.
Thank you very much, Deputy Minister. Indeed, I support your suggestion. I would like to just really say thank you to all of the presenters and the leadership from GEMS for taking the time today to really empower members to understand the very important medical scheme more better. I think this will add to all of our future discussions. As the Committee on Public Service and Administration, at the heart of our oversight and our duties is our care about the public service and the people of the public service, and GEMS is a very important part of that. With that, members, I am going to say thank you for everybody's disciplined inputs and for the well-run deliberations. I thank everybody who participated and attended today. And with that, the meeting is adjourned. Thank you, everybody.
Thank you.
Thank you, Chair.
Thank you, Chair.
Thank you, Chairperson.
Thank you.